This will be a presentation on the management of orbital swelling in pediatric patients. History of present illness and review of systems. An 8-year-old female presented to the emergency department with a sudden onset of worsening right eye redness, ptosis, and pain with eye movements, all developing over the course of 1 week. Her symptoms began with mild discomfort and swelling on the first day, progressed to noticeable redness and mild ptosis by the second day, and intensified by the fourth day, culminating in severe symptoms by the sixth day, prompting her visit to the ED. In her review of systems, the patient reported photophobia and pain with eye movements but denied any fever, weight loss, night sweats, recent ocular trauma, or upper respiratory infection symptoms. These findings guided patient history. The patient has a significant past medical history of bilateral lacrimal gland enlargement, diagnosed 18 months prior, which led to significant ptosis and discomfort. A partial excision of the lacrimal gland was performed, confirming nonspecific orbital inflammatory syndrome. Previous imaging had shown bilateral ptosis with downward deviation likely due to asymmetrically enlarged lacrimal glands. She has no known drug allergies and was not on any medications at the time of presentation. Her family history is unremarkable, with no known autoimmune diseases or ocular disorders, and her social history includes living in a smoke-free environment and attending school without any significant social stressors. Laboratory findings. In the emergency room, the following lab results were obtained. CRP was significantly elevated at 15 mg per liter, suggesting an ongoing inflammatory process. WBC was slightly elevated at 11.4 times 10 to the power of 9 divided by L, indicating a possible infection or inflammatory response. Platelets were also elevated at 492 times 10 to the power of 9 divided by L, supporting an inflammatory etiology. Thyroid function tests, including TSH, T3, and T4, were within normal ranges. Immunology results showed positive ANA at 1:320 titer and positive ANCA, both of which supported an autoimmune process. Myeloperoxidase antibodies were elevated, further suggesting an autoimmune component. Radiologic imaging. Imaging studies included axial and coronal CT scans. The axial CT scan revealed asymmetric ptosis with greater enlargement of the right lacrimal gland compared to the left. The right lacrimal gland showed increased mass effect on the right globe, as indicated by the red arrows. The coronal CT scan also demonstrated this enlargement, further confirming the diagnosis of significant orbital involvement without evidence of abscess formation. These imaging findings were critical in ruling out orbital cellulitis and abscess, steering our diagnostic considerations towards an inflammatory process. Differential diagnosis. Given the clinical and imaging findings, we considered the following differential diagnoses. Orbital cellulitis, a serious bacterial infection of the tissues posterior to the orbital septum, typically presenting with ptosis, pain, and possibly fever. This was ruled out due to the lack of systemic symptoms and negative imaging findings. Preseptal cellulitis, an infection of the subcutaneous tissues anterior to the orbital septum, presenting with eyelid swelling and erythema, but without ptosis or pain with eye movements. This was ruled out based on the presence of ptosis and deeper orbital involvement on imaging. Neoplasms, including both benign and malignant tumors, could explain the mass effect and ptosis. However, the absence of progressive symptoms, normal imaging findings, and normal tumor markers made this diagnosis unlikely. Secondary glaucoma, an increase in intraocular pressure due to an underlying condition, potentially linked to orbital pathology. This was ruled out based on normal intraocular pressure measurements and the absence of optic nerve abnormalities. The final diagnosis was idiopathic orbital inflammatory disease, IOID, a rare condition characterized by nonspecific inflammation of the orbital tissues without an identifiable underlying cause. Key findings that led to this diagnosis included the acute exacerbation of chronic orbital symptoms, including worsening ptosis, pain with eye movements, and severe logophthalmos leading to corneal ulceration. Elevated inflammatory markers such as CRP and WBC, alongside positive ANA and ANCA, suggested an underlying autoimmune component. The patient was managed with high-dose 4-methylprednisolone, followed by a gradual taper with oral prednisone. A multidisciplinary approach involving ophthalmology and rheumatology was critical in managing the acute phase and developing a long-term treatment plan to prevent future exacerbations. The patient showed significant improvement, and ongoing follow-up will focus on monitoring for recurrence and managing potential complications. In conclusion, this case highlights the complexity of diagnosing and managing IOID in pediatric patients. A thorough diagnostic process, including the exclusion of other serious conditions and a multidisciplinary approach, was essential in achieving a positive outcome for this patient. Thank you.